Hello, my name is Chris Butcher. I am a graduate student at Eastern Michigan University. Today, I am presenting part 2 of my thesis. Part 1 was on the supply chain resiliency of a crisis. But since we decided to collapse our supply chains, I had to pivot to understand the policies specific to this pandemic versus other pandemics. This presentation is a condensed elevator pitch of my research. I'm going to go through the data fast. This data might be new to some. I ask that all questions be saved until the end of the presentation, please. Thank you. So, a rift is formed, a split from precedence in the recording, aggregating, and reporting of pandemic data. There are now at least 2 distinct data sets that are difficult to compare to each other. That of pre and post March 24th, 2020. When I say pre-March 24th, 2020, I mean back hundreds of years from the beginning of recorded medical history up to March 24th, 2020. This disparate treatment in the official data dissemination can be linked to most of the harm caused during the pandemic. And by harm, I mean the Hippocratic Oath usage of the harm, more precisely, to abstain from all intentional wrongdoing and harm. The emphasis of this presentation is to show the movement away from benchmark, best practice, standard operating procedures like tracking, following, and treating clinical signs and symptoms, which are the infection of the pathogen, and towards vaguely defined cases and bottlenecked testing protocols. In all past epidemics, pandemics, and endemics, these 2 forms of pathogenic measure, which is cases and infections, shared a one-to-one relationship. What caused us to reinvent the wheel for COVID-19? So looking at this graph, it's a 52-week graph. This graph is centered on the flu season. It goes from August to August, but it's centered on the flu season. It is based on CDC data of all-cause mortality, which includes death by disease and violent deaths, murders, suicides, and overdoses. All deaths are included. What is most significant is that for the first year and a half of the pandemic, the deaths were tracking normally when compared to previous years. So, SARS-CoV-2 didn't cause any significant unexpected deaths for the first year and a half of the pandemic. Now, if we look at the 2019-2020 line, which is the green line at the top, we will see that all of a sudden, a significant increase in all-cause deaths. What happened around March 24th, which is the solid vertical pink line? What happened around then? What changed? The virus hasn't mutated yet. We see from the alpha variant doesn't emerge for another couple months from the small graph on the left. So there's no variants yet. So what changed? What is boosting these numbers all of a sudden? Well, around March 24th, 2020, there was a suite of emergency policies implemented. The data will show an immediate increase in all-cause mortalities following the implementation of these policies. There is enough data to declare a direct causation between the increase in deaths and the emergency policies, which means the policies have become the drivers of the pandemic harm rather than the virus. One significant impact of the policies is an enormous increase in elderly and immunocompromised deaths after March 24th, 2020. Remember, the virus has been in the wild for a year and a half at this point. These massive increases in nursing home deaths take place in a select few mandate-heavy states, as they constitute a large portion of the all-cause deaths in 2020. We now know that the impact of these policies is to uncouple the usual driving forces of pathogen spread, such as infection and clinical signs and symptoms, and instead artificially insert the RT-PCR test, which is the reverse transcript polymerase chain reaction, as the driving force behind the pandemic. So that led me to my question: what are the impacts of these policies on the methodologies and the trends for recording, aggregating, and reporting of data? So we are changing how we record. And gather data. It is clear we are deviating from the best practices of established SOPs developed over the past several hundred years. Everything we've learned about good medicine in the past, we are throwing away. This is Dr. Shi Zhenlin. She is a virologist in the Wuhan Virology Lab. She is known as the Bat Lady of Wuhan. If you haven't heard of her, and you don't recognize her, your functioning, working knowledge of the pandemic is about a 1 out of 10. And by the way, she is wearing the only level of PPE that provides significant protection against mRNA viruses. So when looking at the impacts of the policies on the death rates, we should start by looking at the death rates of the population. So here's what we're going to do. We're going to get rid of the legacy corporate media hysteria. So take out everything you saw on CNN and MSNBC and Fox and all that. Get rid of all social media fear baiting, everything that they say that doing to keep you scared and alone in your home. And we're going to focus specifically and only on the data. So this chart is a population death data taken from the CDC. If we look at the center column titled population, we see that no event decimated the population of the US over the past few years. To go one step further, no event decreased the population of the US below previous year's numbers. So, based on the data, since 2018, no event transpired that was significant enough to slow the growth of the U.S. population. The U.S. population increased at normal expected rate. In other words, there was no viral pandemic. There was a new virus, but not an extremely deadly one. We see the most recent survivability numbers from the CDC at the bottom graph. If you're below 70 years old, you have a 99.5% survivability plus. That is not a deadly virus. So if the population isn't dying, where did all these COVID deaths we heard about on the news come from? So what the policies did is erase the line between dying with COVID and dying because of COVID. That line is now deleted. So all diseases, suicides, overdoses, and murders are all now COVID deaths after March 24th, 2020. This graph shows that immediately after March 24th, in the beginning weeks of April, we show a decrease in all causes of death. Every other disease and cause of death decreased almost the exact same amount that COVID deaths increased. And it shows the following week after that and the following week after that the same thing. We're calling it classification capture. This radically and incorrectly boosted the COVID case and death numbers. If we want to look back and perform oversight on this pandemic, it will be very difficult due to the lack of granularity in the data. They're all COVID deaths. Anybody who died in this time frame is a COVID death. The policies directly impacted the recording, aggregating, and reporting of every single category of death. These policies are causing all data sets across all verticals to be incorrect. Why would we implement policies that create incorrect data reporting and cause a shift of all-cause death to be reported as COVID death. What would be the incentive? Well, the government made it easy to report all causes of death as COVID, and they made it very lucrative to do so. You see in this picture, this is one hospital room in one city, in one state, in one hospital, at one moment. This is $5 million. So in every other pandemic, a case was an infection, but not in this pandemic. If we look at these policies through the filter of a traditional patient-centered curative medicine, which means we want to get the patient healthy, this makes no sense. But if we look at these policies through a filter of a transfer of wealth, this makes perfect sense. So now public health is no longer about a healthy public. It's about getting documented cases. It's about documenting cases for government subsidies. So in the mandate-heavy states like New York, young, otherwise healthy COVID patients recently released from hospital were immediately sent directly to nursing homes to commingle with the elderly and immunocompromised, who at that point did not have COVID. We just saw that anyone under 70 years old has a 99+% survivability rate, but the survivability rate drops quickly with age and comorbidities. Well, the government made it easy to report all causes of death as COVID, and they made it very lucrative to do so. Well, the government made it easy to report all causes of death as COVID, and they made it very lucrative to do so. You see in this picture, this is one hospital room in one city, in one state, in one hospital, at one moment. This is $5 million. So in every other pandemic, a case was an infection, but not in this pandemic. If we look at these policies through the filter of a traditional patient-centered curative medicine, which means we want to get the patient healthy, this makes no sense. But if we look at these policies through a filter of a transfer of wealth, this makes perfect sense. So now public health is no longer about a healthy public. It's about getting documented cases. It's about documenting cases for government subsidies. So in the mandate-heavy states like New York, young, otherwise healthy COVID patients recently released from hospital were immediately sent directly to nursing homes to commingle with the elderly and immunocompromised, who at that point did not have COVID. We just saw that anyone under 70 years old has a 99+% survivability rate, but the survivability rate drops quickly with age and comorbidities. So New York puts the young, otherwise healthy COVID patients in with the elderly and immunocompromised. And on top of putting sick young people in with the previously uninfected elderly, New York prohibits the nursing homes from testing for COVID. Our most vulnerable populations, This is another break in medical precedent. In all other outbreaks, we move to protect our elderly and our immunocompromised. The policies attacked our most vulnerable, the most in need of our protection. So again, on March 20th, 2024, the WHO implements another break from precedents. So they submitted a confirmed case definition of a person with a laboratory confirmation of COVID-19 infection, irrespective of clinical signs and symptoms. So now, with this new definition, the only way we can detect, track, and gain information and insight into the pandemic is through this RT-PCR test. On March 20th, 2020, we stopped looking for infections of SARS-CoV-2 and started looking only for positive test cases. The pandemic is now in the test, and the test is the pandemic. Now, we're looking for cases and not infections. Since we changed the definition of case to mean a laboratory confirmation, a PCR positive test, we are not looking for actual infections, clinical signs and symptoms, or vectors of viral transmission. This definition, in tandem with multiple other definition changes, effectively uncouple our current responses from all medical precedent. If this were a court of law, we would ignore all the evidence, all the eyewitnesses, and focus only on the hearsay. So now we are basing our policy on cases. What would cause us to base all of our pandemic knowledge on a single, narrow testing bottleneck? All our information about the pandemic is now only derived from this test. Why? Well, this test is completely manipulatable. It has a parameter called at this point in the pandemic, we are totally divorced from being concerned with infections, which are clinical signs and symptoms. We are now solely focused on cases. So this test has a parameter called a threshold cycle, which if you want more of your tests to become positive, more of your sample batch to become positive, you crank it up to 40 or 45. It'll magnify it and amplify it more. If you want your sample, your positivity rate of cases to more resemble that of what the infected are, you would lower that down to the scientists and researchers I talked to said it should be around 15 or so. That's what they're comfortable with, around 15 CT, threshold cycle. We're doing it 40, 45, or above. So at this point in the pandemic, we are totally divorced from being concerned with infections, which is the clinical signs and symptoms. We are now solely focused on cases, which is this laboratory confirmation. And the number of cases are based solely on the RT-PCR test. So now we can start to see how the policies are creating a bottleneck within a bottleneck within a bottleneck of data gathering and reporting. We completely decoupled from all previous medical best practices. Since the beginning of medicine, the result is that we now can push the asymptomatic spread theory. About 20 minutes.